Okay, never mind. So it's a very important topic. Though it's only 3% of the time you find breaches. Once you get it in a one as a shock. Unless you are prepared to manage a breach presentation, you will be in real problem when you find out that you have to manage a breach. So it's very important that we have some idea about management of breach presentation. So I'm going to give you a very rough guideline how to manage what is breach and how to manage breach and the types of breach and so on. So, well, when the baby's buttocks or the baby's back is lying at the lying or facing the maternal pelvis rather than the upper area, it's called the breech presentation. Percentage of breech. You have to ask at what gestation do you mean? Because if I tell it at 28 weeks, it will be at 25%. Rather than 3 to 4%. So in the breech, you would feel a palatable mass in the upper pole, which should be the head of the fetus. So that's how when you palpate the lower pole, you will feel like it's something firm structure going, and you don't feel a hard mass in the lower pole. And when you palpate the upper pole, you will feel a palatable mass in the upper pole. When you combine these two, you can say that the baby is in breech presentation and in a longitudinal line. So the problem is these breech babies have a bad obstetric outcome, or their morbidity is worse than cephalic presentation ones, irrespective of the mode of delivery. That's the problem. So even the mode of delivery is cesarean. Hello? Oh, no, so irrespective of the mode of delivery, the outcome for breech is worse than outcome for cephalic presentation. So there are three types of breech that we have to know. One is the extended breech, where both legs are extended up, and they are more close to the head of the baby. Right? This is the extended breech picture that you see here. And there's this flexed breech where the legs are coming down, but they're not totally down. The buttock is still facing down, but you can feel the legs also on a side, right? So that is called the flexed breech. Then you have the footling breech, which is a very dangerous situation where the cord can come out. Cord prolapse is common. Footling breech is when the legs are only coming out rather than the breech. So it's not a compound presentation like the breech and the legs. So it's basically the legs only are coming down. Now, in this situation, there's a lot of space in between the legs and the breech. So the cords can just squeeze in, and that might be a very dangerous situation. Might lead to a thing called cord prolapse, which we will teach you when you come to your finals. It's an obstetric emergency, and it's a dangerous situation. Right? So what are the causes associated with breech presentation? Well, most of the time we don't know. So we call it idiopathic. Idiopathic is we don't know. So without any reason, some babies had breech. But there are so many other things. Preterm babies are most of the time, I told you, 25% of the preterms are breech. So that's okay. If they go into labor is the problem. Because normally preterms don't go into labor, but then rarely they can. And then you become a preterm breech. And if there was a breech presentation previously, there's a higher chance that this pregnancy also you might end up with a breech presentation. So that, of course, is very common. Previous breech, this time also breech, right? Then uterine abnormalities like fibroid uterus, mainly this Mullerian duct abnormalities. Now, today we had a discussion about a lady who had 3 breaches, all past 2 deliveries also breech, and now this time also again a breech, only to see that she has a septate uterus. So that's a Mullerian duct abnormality. We call it Mayer-Rokitansky-Kuster-Hauser syndrome, or there's a syndrome with a long name, but anyway, that is the problem is their division of the uterus is abnormal. I mean, in MAH car, that's totally abnormal, but there can be partially abnormalities like biconvate uterus, septate uterus, and so on. So they also have a high risk of breech presentation. Then any big something occupying the lower segment, like placenta previa. Now, the placenta is in the lower segment, the baby's head cannot come and get engaged. So the baby tends to turn the other way. Right? And any fetal abnormalities like maybe goiters or any tumors, or maybe something like maybe baby's muscle tone is a problem, then you can have a persistent breech. And in multiple pregnancies, it's very common. It is very notorious to have abnormal presentations, which includes even the breech. Right. What are the complications? Why are you worried about breech? Well, it increases the morbidity and mortality of the mother as well as the baby. So in the mother, if you try a vaginal, it might result in prolonged labor. And if before the delivery, they can have a lot of discomforts, they are really in trouble. They'll always tell they can't eat, they have dyspeptic symptoms, and they have early satiety, they can't eat, all regurgitation, everything, right? And if you try to do a vaginal delivery, then there's a lot of manipulation going on at the last moment, and there can be trauma to that as well. And 99% of breaches nowadays undergo cesarean section, and it's a surgery. And we all know cesarean section has its own morbidity and mortality. So a breech presentation ultimately resulting in a cesarean section will have its own problems. Fetal complications, well, its prematurity is one. They can deliver prematurely, then a term. They can have spontaneous rupture of membranes more, and then cord prolapse with fetal distress. The biggest problem that we have as obstetricians, the nightmare is, okay, the baby's body comes out and the head gets stuck inside. Then how are you going to deliver this child? So that's a problem. And then asphyxia, well, that is mainly because if we can't deliver the baby on time, then the baby might get asphyxiated. And if we try to manipulate too hard, interventricular hemorrhages can happen, especially because the head compression and decompression in a breech delivery happens very fast, because the head is what is coming down towards the end. When it's a cephalic presentation, the head compression happens very slowly. With the contraction, slowly the head compresses and engages inside the maternal pelvis, which is not the case in a breech. The breech just comes out within minutes. And so the compression and decompression of the head happens very fast, and that might lead to interventricular hemorrhages. And obviously, if we try to manipulate too much, and if we are worried, and if we get excited, we might even have some fetal trauma at our hands. How are we going to diagnose this? Well, you must not go and diagnose a breech before 36 weeks, because they might turn to cephalic next week, and then you become a donkey. So we normally wait until 36 weeks to tell the mother you have a breech. We will say, okay, baby's in good way. Most of the women, they come and ask us, Baba harila nedi inni. But now at 28 weeks, if someone asks me like that, I'm going to tell much. I will tell, okay, the baby's okay. Looks like baby's okay. Because that the turning of the baby is most important after 36 weeks. Right? And on examination, you can feel that the head is ballotted upper part, and the lower part, you can feel a firm mass. If you're not sure, always go for a scan. Right? Ultrasound scan will confirm your diagnosis. It's very easy. I mean, even a house officer, better before you do any induction or anything like that, confirm that the head is down, because you must not diagnose breech after you have done ARM and do everything, and with something is coming out like a back, then you are diagnosing breech. Would be a nightmare. Don't do that. Always make a correct diagnosis. If you're not sure, take her to the scan machine. You will have a scan machine in your ward. Just put the probe and see. You will see a head in the upper pole and a breech in the lower pole, that anybody can understand. Right? After we diagnose that there's a breech, we normally do a systematic survey of the baby to see whether there's anatomical abnormalities. And we try to take the estimated fetal weight and the head circumference. These are directly related with the success of the breech delivery. So if the baby is very big, like 4 kilo baby, 3.8 kilo baby, and a breech, we are not going to even counsel her regarding a vaginal delivery. It might be dangerous, this thing. And if the head circumference is also very large, that also is a feature that says us we might not be successful with a vaginal breech. Okay, how are we going to manage? There are 3 ways of delivering a breech for you. One thing is the breech, we counsel the patient and we do a thing called external cephalic version. We try to turn the baby from outside, from the tummy, we try to turn the baby towards the cephalic position. So this is called external cephalic version. If we manage to turn and the baby remains turned, then we can offer her a vaginal cephalic delivery. That is the most easiest and the most successful thing to do. But there are some instances where external cephalic version might be failed or it might be contraindicated. Then you have another 2 options. One thing is a planned cesarean section, other one is a vaginal breech. So we are going to discuss all these 3 methods. So what is external cephalic version? Right? It's an attempt to turn the fetus into a cephalic from breech position. And we do it externally, not from internally. There's another one called internal cephalic version or internal podilic version. Internal podilic version is we put the hands in from the vagina and we hold the legs and pull out the legs. That is internal podilic version. Normally not done in a live baby unless it is second of twin. But if it's a dead fetus, you can do that. External cephalic version is you try to turn the baby from outside. We try to hold the head and slowly push the head down and slowly push the legs up, and then the baby tries to turn. Normally done after 36 weeks in primate and 37 weeks multi, because it can return if we do it earlier. Right? It will reduce the cesarean section rate about 25%. Okay, so the method is very important. Someone asking a OSCE. So it's about you have to take the consent. You confirm with ultrasound scan, you will have to find where's the head, where's the back, and where's the breech, and where are the limbs. You will always have to find where is the placenta, because if the placenta is in a position where it obstructs your turning, you are not going to attempt this. Otherwise, you will damage the placenta, and she will have a retroplacental bleed and an abruption, and the baby might die. So, I mean, if it is a very remotely placed placenta, good. But if it is totally obstructing the way of turning the baby, don't attempt a external cephalic version. Once you do your scan and complete your findings, you do a CTG. That is a baseline CTG. And then there are 2 methods of turning the baby. One thing is the forward somersault. Other one is the backward somersault. When you do the forward somersault, what you do is you hold the head and you push the head down towards the knees, right? So the baby is in a bent position. You bend the baby's head more. Once you bend the baby's head, I mean, obviously, if I come and bend your head, right? If I come and bend your head, it will be very uncomfortable in your back. Just bend your head and see as much as possible. Bend your head. So if you bend your head, if you bend your head, it will be uncomfortable for your back. So what you do is, if you can put your back up, so you'll be much comfortable with your back. So you try to, when I bend the baby's head, the baby will try to push the legs and try to come to a neutral position again. Same way, I bend the leg even little bit more. So slowly I bend the leg, head, and slowly the baby will turn the other side, because it's much comfortable for the baby to stay in the neutral position. Right? So if my forward somersault doesn't succeed, if the legs are too much gone into the pelvis, then the baby can't push up. So then what happens is the baby will, we have to try the backward somersault. Same thing other way. But it's very important we don't use excessive force, because that might damage the uterus, placenta, and the baby. That's why we don't normally offer analgesics before this procedure. You have to let the mother tell if it's uncomfortable. If she's totally pain-free, she will just sleep and wait, and we might do a damage to the baby. If the baby is RH negative, but the mother is RH negative, we will have to give rope. Okay, so we normally disimpact the breech and hold this thing, push it down while stabilizing the breech. Stabilize the breech, push the head down, and then try to stabilize the baby. Right? So you have 50% success, but 3% will go back to normal. Another 50% of the successful will deliver. So ultimately, about 25% we can manage the vaginal delivery. We can facilitate it by giving a tocolytic. Tocolytics are medications that will relax the uterus. There are several: salbutamol, the beta-2 agonists, the beta-2 antagonists actually. Salbutamol, terbutaline, these things are. Then you have the calcium channel blockers like nifedipine, and you have this nitroglycerin also is now used. Sublingual nitroglycerin is available in Sri Lanka. That's the only one that's available, right? You can give a sublingual nitroglycerin, which will relax the uterus, and your turning might be easy. Rarely, if a placental abruption or fetal distress occurs, we might have to deliver. It's a very rare complication. Only about 1 in 200 you find, right? And if there's a membrane rupture abruption, you go and do a delivery. So it's a very important when you are counseling the woman, you can say that urgent delivery might be needed if something goes wrong during this procedure. But you can't go and turn every baby. You have to see whether there are any contraindications. There are absolute and there are relative. So you can see there are absolute contraindications like cesarean delivery in the past. The scarred uterus, I'm not going to dabble with the scarred uterus. If the scar just gives up, I'm in shit trouble. It might kill the baby. That's the problem, right? So antepartum hemorrhage is there. You're not going to do these things. Fetal compromise if the baby is small. If the baby is weak, I'm not going to go and turn the baby, because ultimately even turning the baby might not help a vaginal delivery. Baby might still become compromised, right? So oligohydramnios, very low lipo. I'm not going to try to turn it. Might damage the placenta. I mean, I'm worried about it. Rhesus isoimmunization is if the mother and baby had a mixture of blood and the mother is Rh negative. Now these babies are weak and there can be more mixing, and that might be dangerous. If there's severe preeclampsia, mother is toxic, there's a lot of fluid collected in the abdominal wall, and us turning this baby might be virtually impossible. Relative implications are only one past cesarean section, fetal abnormalities, and maternal hypertension. Right? Okay. So if we cannot achieve a vagina external cephalic version, then we have to deliver this baby by breech, or we have to do a cesarean section. So there was a trial called the term breech trial. Now this trial told about what is the success of allowing a vaginal delivery in a breech percentage. Results were stunningly controversial, where the results came as elective breech delivery is much more riskier than elective cesarean section. That day onwards, the breech presentation attempting to deliver vaginally reduced drastically, because people didn't want to get any legal implications by supporting a woman with a breech delivery. I mean, if something goes wrong, they will go and say, in the trials have told that it is bad and you offered me that bad thing, and look what have you done to my child. So that is a problem. Because of that, because of these legal implications, the doctors okay, sorry, it got cut. Sorry for that. So once in a blue moon, you might get a breech, coming in labor, and when you are not seen, when you are not practiced, and if you don't know much about breech, then of course we are in big trouble. So that's why we try to do, at least in mannequins and in emergency obstetric courses, we try to teach how to deliver a breech, right? Okay, why is my this thing not going? Okay, so though it is not much common now, a vaginal breech, it's important to know how to deliver a vaginal breech, right? So the ideal candidate for a vaginal breech would be extended breech presentation, not the second or the third. The first one I showed the picture, and the weight should be less than 3.8, but ideally it should be less than 3.5. The baby should be uncompromised with a good level of oxygenation, and the head should be very, very well flexed. The flexed head is easy because it will give you the lowest possible diameter of the head. So do ultrasound scan to see if the baby's head is very well flexed. If not, don't go and attempt a vaginal breech. So normally we don't do ARM and do oxytocin inductions and augmentations in the breech. We allow them to come into labor spontaneously, and we'll see how the baby descends down spontaneously. And if it is not descending properly, don't go and attempt a vaginal breech, go and do C. So when the breech comes, so when you have to deliver a breech, so there's a method you do it. So you all of a sudden someone diagnoses a breech and they calls you, doctor, may make undiagnosed breech check then breech deliver. Now what you do? You are the house officer, you are the only doctor there. You run to the scene. You explain the mother, baba tattaming procedures deliver support and you call for help. SHO register line board අම්මෝ ලොකු සර්ටත් ඉක්මනට එන්න කියන්නේ කියලා නර්ස් කෙනෙක්ට කියන්නේ. Anyway, ලොකු සර් එන වෙලාව වෙනකම් මෙයා නම් ඩෙලිවර් නොකර ඉන්න එකක් නෑ. The mother will deliver. So you have to get ready. So what you do is you are going to put the patient in lithotomy position, not the dorsal position. It's a lithotomy position where the legs are high up. And then you give a good infiltration of local anesthetic because you have some procedures to be doing. You better give a episiotomy, right? And you keep your hands off. Don't put your hands in. The more you put your hands in, you're asking for trouble. Don't put your hand in. Let the baby come. You call this breech, when it is coming down the perineum, you call it climbing of the breech, not the crowning of the head. Not the crowning, it's called the climbing. When the breech climbs, you can give a good episiotomy, right? You give a good episiotomy, and so the breech comes, allow to deliver. Once a leg comes, allow it to deliver until the popliteal fossa is seen. Once you see the popliteal fossa, so here the popliteal fossa is seen here. When you see that, press from there and the baby's leg will jut out and get the other leg, pull it out. Once the baby in this position will be on a side, if you like, you can use this maneuver to hold the hips and turn the baby to a sacro-anterior position. It's not essential though, but you can do that. Once you are in the baby's in the sacro-anterior position, don't pull. That's a take-home word. Don't pull the baby, just allow the baby to come down. Right? Allow the mother to push the baby down. If you pull it, the baby's head will extend and then you will not be able to deliver this baby, and that's a big trouble. So what you do is, you allow the baby to come down. They say if you are unable to manage, deliver a breech, that's a fault of the obstetrician rather than the mother or the baby. So if you go and try to do unnecessary stuff, then you will fall in trouble. Just allow the mother to deliver the baby. Don't do anything. Once the baby's back is coming out, allow her to push, and you cover the baby with a small towel, right? And when the scapular border comes, the scapular border here the scapular border is coming. See, when it comes, you know now the hands are close to be delivered. Now put your hands slowly in and see whether the hands are extended or flexed. If it is flexed, it's very easy. What you have to do is you have to just pull the hands out. if the hands are flexed, or if the hands are kept down. If the hands are kept up, like looking at the sky, then of course there's a problem. Then when you put your hand from here, you will not feel the hands. So then you have a thing called this low set maneuver, right? So low set maneuver. Okay. So the low set maneuver is the maneuver that to deliver the hands. Extended hands. Extended කියන්නේ අත් දෙක උඩට දාගෙන ඉන්න. අත් දෙක උඩට දාපම මට අදින්න බෑ. මොකද pelvis එක ඇතුලේ අත් දෙක තියෙන්නේ. So the low set maneuver is, I have these photos for the low set maneuver. This is the low set maneuver. So see, this hand is extended. Now this there's a huge distance from here to here. I can't deliver this hand. So what I do is I turn the baby 180 degrees to the other side. See, this hand is down. Now this hand is down, this hand is up. So I turn the baby 180 degrees to the other side. Then this hand will be very close for me to deliver. And then I turn again another 180 degrees to the other side. So here the hand is down. When it comes to here, it will be down. So basically it is like rotating the baby 180 degrees one side and the 180 degrees the other side. It's like a screwdriver. And that will result in the shoulders coming down. Even the extended shoulders, like see this E picture, will be down when you turn the baby second time 180 degrees. And then you can pull the hand down. So that is called the low set maneuver, right? You can see in the internet, just type in the internet video of low set maneuver. Then they will show you. Once you have delivered the hands, now the head has to be delivered, which is the most difficult part. Here, don't be in a hurry. Wrap the baby very well with a warm cloth and wait until, just support the baby's back and wait until you see the nape of the neck. So you can see the hairline of the neck. Once you see the hairline of the neck, then you know the hairline can be seen only when the head has descended down from the pelvis towards the pelvic bone. If you can see the hairline, that means the baby's head is very close by. Then, without any fear, you can do this Mauritius-Smelly weight maneuver with, and in this Mauritius-Smelly weight, this is the Mauritius-Smelly weight maneuver. You see, you put one hand, you support one hand, and that is pushing the chins and the cheeks down. And the other hand is trying to stabilize the head and keep the head flexed. That is the Mauritius-Smelly weight maneuver. Your assistant can push from fundus area to keep the head more flexed. So Mauritius-Smelly weight, you put two hands, you will support the hand in one hand, support the baby in one hand, and with that same hand, you flex the cheeks. And from the other hand, you flex the head by pressing on the neck. The other delivery method that can be done is the forceps. Forceps is what you do is you have to find long forceps. Normally for a breech, we have this Piper's forceps. This is a Piper's forceps. You can tell your assistant to lift from the leg up and slowly put the forceps blades from below, not from up, but from below you put the forceps. And forceps, when you pull up, the baby's head will turn, flexing the baby's neck. So that is the forceps delivery. The other method is Mauritius-Smelly weight maneuver. Both are acceptable. It depends on your expertise. For example, now I am much more trained to deliver with the Mauritius-Smelly weight maneuver. Some people will do the forceps more commonly. It depends on your experience and if you're success. So whatever you have been trained, you can do. Right? So these are the main two methods that we do breech delivery, head delivery, right? Okay. So I will give you a small. Right. If you can see me now, the lower hand where the baby's head is supporting will be like this. Don't put it inside the mouth. When you push like that, the mouth might tear off from this side. Right? Babies' mouths are very fragile. So do it like this. One hand do it like that, other hand press it like this. Then the baby's head will be flexed. See? Don't do like that. That might be dangerous, right? That is the Mauricio-Smelly way. When you're putting the forceps, you say this is the baby. Tell your assistant to hold the legs up, and the head you put the forceps from down. Now, if it's a forceps that you put from the to the head from if you put the forceps to the head in a cephalic presentation, you put the forceps from up like this up. But in a breech, you lift the legs like that and you put the forceps from down. There is a difference between a breech forceps and a cephalic forceps. Right. So that's about it. Any questions about breech or? But anyway, you will have. We will do two things when you come to the final year. One thing we will teach you hands-on experience about delivering a breech in the emergency obstetric course, and the other thing is we will have another ward class on how to deliver a breech. So ultimately, with these three parts of lectures, you will be very, very conversant with managing a breech. Okay. Okay then. Anything?
Excuse me, sir. Sir, why do we give the anti-D in that?
If it's a negative mother, if the mother is negative and we are doing a lot of manipulations here, there might be a fetal-maternal bleeding. So normally, when you are doing an external cephalic version, when you are trying to turn, it might whatever safe you are, you might go and touch the placenta. You might be milking the placenta here and there might be a little bit of small vessel bleed, and they will get sensitized. So we normally give, if the mother is Rh negative, we give anti, right?
Okay, sir.
External cephalic version has its own risks. Yeah. Okay, then we'll leave for now.
Excuse me, sir.
Yeah.
Sir, if there is multiple gestation, shall we do vaginal delivery, that forceps these procedures for the breech presentation?
Now, if it's a multiple pregnancy and the second twin is breech, if the first twin is breech, you're going to do C-section. So a twin pregnancy or twin pregnancy only you can allow a vagina. Multiple, more than twins, you have to do a C-section if it's triplet or quadruplets. If the first baby is breech or any other presentation, you have to go and do a C-section. Only indication for vaginal delivery in a twin is the first twin is cephalic. When the first twin is cephalic, if the second twin can be either transverse, either breech, either cephalic. If the second twin is cephalic, you can allow the baby mother to deliver the second twin as normal. If the second twin is transverse or breech, then you do not external cephalic version, but you can do external cephalic version or you can do internal podalic version. So what is external cephalic version? External cephalic version is when the second twin is breech, you try to get the scan machine to the labor room and try to turn the baby cephalic, and then you slowly stabilize the head from your tummy, mother's tummy, and do an ARM and start syntocinon to increase the contractions and deliver the second twin. It is true for even transverse live. You have to turn the baby into a cephalic position, stabilize the head, start some syntocinon, do an ARM, and allow the baby to deliver. But other method that is possible, and if you are conversant, is a thing called internal podalic version. In the internal podalic version, what you do is you do a scan. Now, first twin is delivered, second twin is breech, and now you have to deliver the second twin, or second twin is transverse. What you do is you do a scan. You find where the legs, the feet are in the scan. And without rupturing the membranes, you now put your hand in and push towards where the legs are. Now, when you are doing like that, definitely the membranes will rupture. But before the fluid has gone out, we hold the legs. We hold the legs because we have done a scan and we know where the legs are. We hold the legs and we pull out the legs from the vagina. Once you pull out the legs, the rest of the body comes out without much issue because these babies are small. In twin pregnancy, the babies are small and they will nicely deliver without much difficulty, right? So that is called the internal polylic version. Normally, if the second twin is breech and the membranes are ruptured, then of course it's very difficult to find the legs because the uterus starts contracting and the legs will be very difficult to find. But not the case when the membranes are intact, second twin. So normally, twin pregnancy, you can allow vaginal breech delivery in the second twin if it is dichorionic diamniotic and if the first twin is cephalic only. Okay, but you will have this type of this lecture, that part will be taught to you in twin pregnancy. Okay, right? So I will send these slides to the demonstrator. Any one of you want, you can ask, right?
Okay,
No.
sir. Thank you, sir.
Okay.
Thank you, sir.